Hello, my beautiful and courageous friends. It's Natalie Kelly here. And today I'm here with Dr. Laurie Chaikin, who's a rehab optometrist here in Alameda, California.
When the waves came and when the storm raged, found myself falling into the ground. When the wind blew, that's when it fell through, and I don't know how to turn it around. I know there's more to me than the wreckage you see. There's more to be. I'm still on the journey. I'm still on the journey.
Laurie is just such an angel. She is a doctor who helps lots and lots of people with brain injuries. I've seen the people who come in and out of her office, and she is an angel. An angel. So, Laurie, can you tell us a little bit about your practice?
Sure. Well, I'm an optometrist and an occupational therapist, and I've been working in rehab for decades. And I've been working with, started working in pediatrics and started also working with adults at the same time. Very early on, while I was still a student in optometry school, I started getting referrals to work with brain injury patients, and it began way back then. At some point, I went through the certification program with the COVD, which is the College of Optometrists and Vision Development, and they offer a certification fellowship program for optometrists that want to develop special credentials to work with more, to work in rehab. And some of those doctors tend to specialize more in behavioral or developmental problems, and they call themselves behavioral optometrists or developmental optometrists. Others work more in the neuro areas with patients with head trauma and stroke and other neuro problems, and so they might call themselves neuro optometrists. So there's different areas that really people specialize in within optometry.
Mm-hmm. Well, I can tell you that the work that you have done has helped me more than anybody I've seen, and I've seen a lot of people. So
Wow.
I'm really excited to have you here today, sharing your knowledge with all of us.
I'm happy to.
So we can help everybody else out there. Now, when we think about brain injuries, we generally think about cognitive issues. Do many people with brain injuries also have visual deficits?
Well, I have to say that the sample that I see, my patients, might be a bit of a biased sample, and of the people that I've seen, I can't think of one that doesn't have visual problems. So it's very prevalent, it's very common, and someone can have what would be considered a visual processing problem, and in addition, have a visual problem as well. So I teach courses to OT, PT, and speech on how to identify vision problems, and what I tell them is that it's really important to first differentiate between the vision component of a brain injury and then look at the visual processing or visual perceptual part of it. So those are two separate areas, and if you, for example, your two eyes are not lined up and you're seeing double, but maybe you're seeing double but you can't talk about or describe that you're even seeing double, that needs to be identified first before you can even do a visual perceptual evaluation. So it's my orientation and in the way I teach other therapists that needs to be identified first.
Mm-hmm.
So the process of taking in information from the point of view of, are the two eyes lined up? Are they working together? How well do they work together? Is the image clear? Does the person need glasses? At what distance do they need glasses? Are they seeing a whole image? Or is part of their field missing? Is their vision stable, or is there a binocular instability, or the images are moving around? All that needs to be identified first before you can look at what do you do with the information once it gets to the back of the brain and you start working on that information.
Now, why is vision so affected with brain injuries? Can you explain to us how the vision and the brain are connected?
They are intimately connected. In fact, the eyes are fairly extraneous to the process of seeing. You actually are seeing with your brain.
Amazing.
It's very important how the eyes are lined up, but there are many different levels of neural organization of vision and the brain. So at the very basic level, your two eyes need to be lined up. Visual processing occurs once the information hits the first way station inside of the brain, which is in the midbrain. And you don't actually see with the information as it comes to that level, you're not seeing yet, but there's a whole lot of interpretation that's going on at the level of the midbrain. And then as it arrives to the primary visual cortex, right in the back of the head, the back of the brain, that's where you first have the understanding that you're actually seeing.
Mm-hmm.
However, there's all kinds of interactions. There are from the visual cortex and through the parietal lobe and the temporal lobe and the frontal lobe, there are millions of connections that are occurring. They help you to understand what you're seeing.
Mm-hmm.
So the proprioceptive system, the tactile system, the somatosensory system, the olfactory system, there is not another sensory system that doesn't interact with vision. And so that's why if there's damage anywhere along those pathways, both with how visual information comes back, if the speed of processing is slowed down or affected, or any of those interconnections are affected, that downstream effect of that will be that vision is altered and affected. And we'll be talking more about some of those ways as we go along.
Yeah, so that explains why, for example, me with my brain injury, I felt like I could see something, but the image was getting to my eyes and my brain couldn't understand really what it was or comprehend it.
Right.
Because I could see it, but I couldn't comprehend it, if that makes any sense.
Right. So the understanding of what you see occurs in the next set of synapses on either side of the visual cortex. So the primary visual cortex, you receive the image, and then on either side of that are called the visual association areas, and that's where context and meaning and understanding of the image that you're seeing occurs.
Mm-hmm.
So if there's an impact in those visual association areas, then you'll have confusion about, well, I see that, but I don't feel connected with it, and I don't really understand it. What I see it, but what is it?
Yeah, exactly. And then processing the information was completely exhausting. So
Right.
why does that feel so exhausting to somebody with a brain injury to just process visual information?
A major part of our sensory organization is automaticity. So when we have the process of walking down the street, you don't think about walking. You don't think about stepping off a curb. None of those processes are in any way part of the desktop of processing. So imagine a computer desktop. If you have too much stuff loaded on your desktop, your computer starts to get confused and it crashes and you have to restart it. Mm-hmm. If we have too much stuff that is not automatic, we have to think about it, then our organization becomes less efficient. So when you have a brain injury, the processes that were automatic are no longer automatic. And so now you're having to think about walking and talking, walking and processing lots of simultaneous information, moving through space and being able to order and organize all the other information, which really touches on something else that you may be asking me, but I'll address it now, and that is visual overwhelm. Mm-hmm. That when you walk into a complex visual environment, there actually is a visual overwhelm syndrome that we have identified. And in that situation, it's a combination of lights, and it's a combination of a lot of sensory information that you can no longer organize. And you may walk into a Target or whatever, big box sort of a shopping experience, and now there are so many different pieces of information that are all calling for your attention. Yeah. And they're very specifically designed to call your attention. So if you can no longer filter what's important and what's not important, then everything is calling your attention. What calls your attention then calls your eyes to move over and say, well, what's that? What's that? What's that? And so you're looking left, right, up, down, near, far, and it's no longer in an organized manner. That all comes back to central visual information processing with peripheral visual information. And it's a very common breakdown that occurs where the information that's coming from central vision and peripheral vision is no longer organized in a normal manner. And so you're being pulled in a million different directions, and you don't know how to organize it. And
that's so right on.
People who experience that, they can only tolerate a certain amount of that, and then all of a sudden they go, I have to get out of here.
Now.
Right now.
Yeah.
Or I'm going to fall apart.
Yeah. Panic.
And you panic, anxiety,
yep.
Shut down, and you have to go into a calm situation so you can regroup and you can get yourself back together.
Yeah. I can't tell you how many times I've loaded up my grocery cart and then had to run out of the store, just abandon the whole thing.
Wow, really?
Yeah.
Wow.
It's like, I gotta get out of here. No shopping done.
Oh.
Go home.
Wow.
Yeah.
And part of that is also the lighting. So the fluorescent lighting that occurs in most of those shopping situations has a huge effect on brain injury. And one of the reasons why is that fluorescent lighting has a lower flicker frequency.
Mm-hmm.
So flicker frequency
Easy for
threshold.
you to say.
People with brain injury have a much lower threshold to that. And so the light is actually flickering and you become more sensitive to it.
That's true.
So it's not only that, but it's also that the rate of flicker is something that people become sensitive to. Now, most people with normal brain integration can tune that out, but people with brain injury may not be able to tune that out. And so the flicker rate itself becomes something that is entraining the brain pattern. So your own brain pattern becomes influenced by that rate of flicker that now is causing you to become disorganized, and you can't control it.
Fascinating.
So that's why we use...
So the flicker's going at a certain speed.
Right.
I think it's 1,000 flickers per second.
Mhm.
And the brain starts to entrain with that and create the same
Correct.
brainwave pattern,
Because it can't not.
which is why I used to walk in a room and have to leave immediately if there was a fluorescent light on.
Correct.
Wow.
I have a patient who is a doctor, MD, public service sector doctor, that had a head injury, and as a result of that, one of her remaining triggers is fluorescent lights that is so severe that when she walks into a particular fluorescent lighting, first her speech goes, she can no longer talk, and then her lower extremities go and she's on the floor.
Wow.
She can no longer walk. And so she now knows what those triggers
I
are,
can relate to that.
and she knows what to do. I mean, she has
Turn the light off.
turn the light off. She has visors
yeah.
and hats that she uses, and she's tried some different colored filters that didn't particularly help her, but we've had other people that were able to respond well to different colored filters.
Yeah.
It's a way to deal with
So in that person's example, that's a perfect example of how the visual overwhelm can trigger the brain to shut down and then nothing else is working.
that. Right, exactly.
Yeah.
And then if you add to that someone that also has auditory overwhelm, combined with the visual overwhelm, it's just a recipe for disaster.
Right. Makes grocery shopping very difficult.
It does.
So I have heard head injury survivors say, I can see, but I feel like I'm blind.
Mm-hmm.
I have to operate in the world just like a blind person does. Can you explain that so people can understand? What does that mean? I don't think the general public could have any concept of what that means.
So they're no longer able to respond to their visual information isn't making sense to them, and part of that may be that the tactile system isn't really working for them. It's no longer operating for them. It's no longer integrated with them. So the somatosensory system, the proprioceptive system, so that we walk through space as a multisensory individual.
Yeah, where
organism.
everything's kind of flowing harmoniously,
Right.
usually.
But if vision becomes disconnected from the rest of the sensory system, then people feel like they're blind. That it just isn't making sense to them, and so then they would act more as a blind person, and that they would start doing what's called cruising, where they need to actually touch things to be able to understand where am I in space. They need to define the borders and the boundaries of where they are, and that makes them feel like they're walking and moving around like a blind person, when actually
I do that all the time, and I didn't know there was a name for it.
that's
Why
right.
it's so fun to talk to you, because you get it.
I've seen you do it.
You have. So how are the visual problems affecting the dizziness and the disorientation and lack of sense of where you are in space? How
So
is that connected?
The balance is a key part of vision. We have multiple balance systems that are redundant for our body. One of them is the inner ear, the inner ear that has 3 different semicircular canals that help us to figure out where our head is oriented in space and to provide a stable platform for vision. The other is the eyes, and the eyes are connected with these semicircular canals, where the horizontal canal very specifically organizes and hooks up with the eye muscles that move right and left. The vertical one for moving your head up and down connects with the vertical eye muscles. And so, and then your proprioceptive system, the little muscles and tendons in your body are also telling you where you are in space. If any of those is off and no longer communicating accurate information, then it's going to set off your motion disruptor sensors, and you'll get a dizzy response. You'll feel dizzy. So that's part of where I utilize Cindy Gibson Horn and refer to her for the motion therapeutics for the VEST evaluation. And there's been many times when we've been able to provide input through the proprioceptive system to help to stabilize the semicircular canal vestibular system, which then has direct action on the vestibular ocular reflex to calm everything down and provide a more stable platform. And that's why I love working with the VEST technology, because it will have direct impacts with vision.
Yeah.
Sometimes immediately and sometimes less so. It doesn't work 100% for everybody, but we've had some great results, and we have more than a handful of patients that we've been able to measure. It's been probably over 10 patients now. We've been able to measure immediate improvements in vision as a result of donning the vest.
Right.
That will affect eye movement strategies, eye movement control, depth perception, and a sense of being connected with the world.
Yeah, and I'm one of those people, and I can tell you it's made a huge difference. And we have a video, if people are interested, of the visual changes that happen by putting the vest on. And we also have a video of Cindy talking about the vest for
Great.
more information. Yeah.
Great.
Yeah.
And one of those people is Rebecca, who hopefully will be a guest on this show someday, where when she put the vest on, she described how she felt like her feet had suction cups on the bottom.
Which is a good feeling when you have a brain
Right.
injury. Yeah.
And she felt like that she was really connected in a way that she hadn't been for probably two decades.
That's amazing.
20 years. And
That's really amazing.
she's partially sighted, and during this trial period with the vest, she stopped using her cane. She just stopped using her cane because she
great.
didn't feel like she needed it. And she's partially blind,
Yeah.
and so she needs her cane, but she wasn't using it. It's pretty amazing.
She is pretty amazing.
Yeah.
So what other kind of tools have you found to be really helpful with people, for people?
Well, there's many different tools. There's the vest. There's the color therapy. There's couple different ways that I use colors. One is first to understand that the visual system has many non-visual light receptors, and those non-visual light receptors go directly to the hypothalamus, pineal gland, pituitary gland, and they help to provide input into balancing the hormonal system. And we can use light therapy going directly into the eyes to help to contribute to rebalancing the system. And sometimes we can help with light sensitivity, extreme light sensitivity, by doing that. Other times we can't, but that can be helpful with that at times. We can use it for helping with sleep dysfunctions and resetting circadian rhythms. Can also help with that. Sometimes I use light therapy by tinting the lenses a particular color. And so I'll have someone like what you did go through and try different filters and see which one has a certain effect. And you found that there was a particular color that helped you feel more relaxed and helped to enhance vision in a certain way.
I felt like my whole body could suddenly relax. It was like this, I've been starving for that color.
Exactly, and that's the response that we're looking for. Not everyone has that response, but a number of people do, and it always amazes me that the responses that people share with they'll say that different colors help their whole body to relax. One person said that all the colors made the world look drab except for one color, that all of a sudden everything turned on, and that's what we're looking for. And some people, there's no color, and they don't have a response to any particular color, but it's great when we do, and it's really cool when it does.
It is really cool. It's very helpful.
We also use different therapies from a vision therapy point of view. So we'll do different exercises and activities to help the system to reorganize. Like we'll use the Brock string or vectograms or different techniques to help reorganize vision. So
and some of those exercises are on your website, aren't they?
Some of them are, and
you can find that there.
They can find it there, but I don't recommend just trying them. They really need to go to a specialist to get diagnosed, because you can't diagnose yourself. You need to go to someone that specializes in this area. And I would recommend you can go to the covd.org website as one way to find a practitioner. You can also go to NORA. NORA is the Neuro Optometric Rehab Association. They have a website where you can find doctors that are specializing in this area or therapists that are specializing in this area.
Great. That's wonderful. That's such a valuable resource, because it's hard to find people who really understand these visual issues.
It is hard to find.
Yes.
And I get so frustrated and angry when I hear the stories of people that have been to so many doctors and no one is diagnosed. Like, for example, your issue, I was shocked to hear that no one had identified your particular issue, and I'll just share a little bit about what the things that you are having to deal with. What happens to Natalie is when she's looking at something right in front of her, she has a particular way that her eyes work together. And there's a little bit of a vertical misalignment of her eyes. When she looks to the left, one of her eyes will go down relative to the other eye. When she looks to the right, it'll be just the reverse, where now the right eye may go up and the left eye goes down. That makes it really, really challenging, because now the platform for stable vision is constantly changing. And she was wondering why she was constantly feeling so disoriented, and that's why. But wherever she looks, the visual platform is different.
Yeah.
And what makes it particularly difficult for her is that there's no real prism that we can work with that will make it right, because the moment she looks to the left or the right, the prism will no longer be correcting appropriately, will be actually working against her.
Right.
And so we're needing to approach that in a different way of working with.
And one of the things that's happened for me that I hear over and over and over is that I went to probably 12 neurologists, neuro ophthalmologists, doctors, so many people, physical therapists, and nobody identified any of this.
Wow.
So, it wasn't until I found you and the Neuro website that I started to go, oh, it's not just me.
Right.
I'm not crazy.
Yeah.
This really is challenging. And
it's so upsetting that you were told that you're crazy.
Yeah.
Rather than that there was an actual problem.
Yeah.
That was identifiable, measurable.
And when I'm walking down the street, everything's bouncing.
Right.
And having a very hard time figuring out where the floor is.
Right.
And yeah. So that's why we're doing this.
Yeah.
Yeah. We don't want anybody else going through that.
No.
Yeah. So the kind of practitioner that would be able to diagnose these issues would be a behavioral optometrist?
A behavioral optometrist, or someone that calls themselves a developmental optometrist, or someone that calls themselves a neuro optometrist. And many of the behavioral optometrists, they may work more in pediatrics, but they have the skills to work with adult neuro as well. Mm-hmm. And a wonderful resource also is a book written by, she's known as Stereo Sue.
Oh, yes, I read her book.
You read her book?
Yes.
And it's called Fixing My Gaze. And she is like the poster child of working in neuro. And it's really her experience as a 40-year-old woman with strabismus that was a pediatric case. She had four surgeries that made her eyes look normal, but she never had depth perception. Mm-hmm. And she's the poster child for neuroplasticity in the visual system, because she was able to demonstrate that at the age of 40 plus, once she got the correct prescription, the correct identification of what the problem was, in her case was also a very small vertical imbalance, and then she had vision therapy to teach her brain how to work with both eyes together, she started experiencing depth perception for the first sentient time in her life. And there are now, this is a huge area of acknowledgement in the vision research community, that they are now willing to acknowledge that there is such a thing as visual plasticity in the neural system. And it'd be fun to do just a whole talk just on the research that's out there on visual plasticity, neuroplasticity in the visual system that demonstrates it over and over and over again, that someone with a torsion in their eye, where their eye rotates, that they can actually learn to unrotate it. That there are methods for doing that.
That's really exciting.
And yeah. There's a lot out there.
It's really exciting because so often you see in the literature that this can't be fixed, or you hear from your doctors, there's nothing we can do about it.
Right.
So this is really kind of revolutionary to think that we can have neuroplasticity and repair.
That's right.
Our eyes and our vision.
The
you
people,
see that.
I see it every day. And the people that originally said that neuroplasticity only exists in the visual system up until the first year of life have now recanted and said, we agree that visual plasticity it is possible for the adult brain to become, to recover and to gain new skills. And even in the area of low vision, which is another area that I work in, people that have gone blind from macular degeneration, we can actually retrain other portions of their retina to hook up with the visual, the area of central vision, which is 70% of the visual cortex is for central vision. And we can retrain the eye to hook up with that area, even though there's no actual area of vision left.
That is amazing.
So,
that is amazing.
There's a lot of neat stuff.
Well, one of the ways that you've helped me is that I've been trying for 3 years to do the visual rehabilitation, but it's been so difficult for me. I could do 5 seconds or 8 seconds of the exercise and then be done for the whole day. Like, I just need to sleep for 5 hours.
Right.
And so one of the things that you had taught me about was calming the nervous system down beforehand.
Right.
With the vest and the colored glasses, so that I could start then doing the exercises.
When you have a system that's completely stressed out, when there's so much central nervous stress, central nervous system stress, that you can't pile more on top of a system that's already completely disintegrated. First, you have to start with calming, and let's just develop a baseline of functionality so that we can now start stimulating it. So vision therapy may not be the most appropriate thing to do right away. You might need to start with nutrition for the brain, like working with the oils, eating the essential oils that the brain is starved for, or other nutrients that the brain needs. I mean, having a nutrition specialist talking about that would be a great thing.
I have one.
You have one? Great.
Yes, I have a video for that too.
Great, you have a video for that. That's great.
We do.
Good.
We're covering all the bases.
Great. So starting.
And I'm glad that you're mentioning it.
Yeah, that, and then the color tints to calm the system, and the vest, all those things.
Yeah.
And then we can start.
Yeah. Oh, that's exciting.
Yeah.
Very exciting. So do you want to look into the camera, and do you have a message of hope for brain injury survivors that you'd like to share?
I know that it's a really long road to hoe to have a brain injury, and I just really want to encourage you to keep working on it, that this is a system, it's your brain, and it continues to want to work towards normalization. There are so many different opportunities and therapies that you can try. Sometimes it's a matter of finding the right therapy at the right time when you're receptive to it, and to continue working, throughout the day, every day. And you may not be ever 100% normal, or that may be a possibility. And I'm never one to tell you what you can or cannot do. No doctor should ever tell you what you can or cannot do. And I'm going to end with the words of one of my patients, Jim, who had a head injury, and he was in an automobile accident. He was a triathlete, and I'm going to say he is a triathlete because he's back to doing it. He had a terrible, terrible shoulder crush. His entire shoulder just became crushed. He had so many different surgeries, and he ended up getting infections in the shoulder over and over again, and they would have to take out the shoulder and put another one in. And his doctor, he finally found a doctor that was the right doctor for him. But along the way, what he would tell his doctors, that would tell him, Jim, you're never going to be able to swim again. Jim, you're never going to be able to bike again. Jim, you're never going to be able to run again. As he would tell them, doctor, It's up to you to find the best shoulder for me to put into my body. It's up to me to manage my expectations. And I just love that.
Very nice. That's great.
And Jim, at the age of 60, is running,
That's
is
beautiful.
swimming, is biking.
Oh, that is just such a perfect ending.
And he's a very positive person.
Oh, that is a perfect ending. It's up to you to manage your own expectations.
That's right.
And it's up to the doctor
That's
to figure
right.
out how to help you.
Don't let anyone tell you what you can or can't do.
Beautiful. Well, thank you so much, Laurie, and thank you so much for the work that you do with brain injury survivors. It's just
My pleasure.
very, very valuable, and we're grateful.
My pleasure. Pleasure to be here.
Turn it around. I know there's more to me than the wreckage you see.